Hello, everyone. Welcome back to Pulm Peeps and welcome to 2026. We were recording just shortly after the new year. We're excited to be back together and to bring you another fantastic episode. Furf, how you doing?
Doing well. I'm very excited to be talking about pulmonary hypertension again. This will be the second podcast in our Pulmonary Hypertension Guidelines series. But yeah, Happy New Year, Tom, Rupali, Christina. It's great to see everybody. Another exciting year of Pulm Peeps. How was your guys' New Year?
It was great. I spent it here locally in Baltimore, nice and cold, but some beautiful fireworks. How about you, Tom?
Good morning, everyone. Yeah, I was also here in Baltimore. I did get to see some of the fireworks and had a low-key, relaxed New Year. So no objections from me.
Yeah.
Monty, were you traveling?
No, did a staycation. So got some great football in, both college and NFL, and saw a few movies. Maybe a topic for another conversation. We could talk about our favorite movies. But I saw Marty Supreme, I saw The Housemaid, and I saw Avatar. All would recommend, though.
Right. Yeah, Marty Supreme was great. That's great. And the Dogged Determination. We should make a Marty Supreme about podcasting, about medical thing. I love it. Yeah, next year maybe we'll do a Pulm Peeps escape to warmer weather for New Year's. But yeah, today we're going to do our second episode in our Pulmonary Hypertension Guideline series. As a reminder to everybody, we're looking at the 2022 ASC ERS Guidelines on pulmonary hypertension. These are the most recent ones. They're the ones that are really guiding practice right now. For those of you who have not listened to episode 1, we recommend you go check that out. You can listen to this one as a standalone, but that has a bunch of intro and will explain where we're at now. So we reviewed a lot of foundational material about the diagnosis and definitions of pulmonary hypertension there, and now we're going to dive into episode 2.
Thanks so much for Fia. And we know for most people, maybe aside from you, that pH can be a really intimidating topic. And that's why I know when Tom and Rupali proposed doing Pulmonary Hypertension Guideline series, we were all for it just to make sure everyone has a great foundation and framework to think about patients that you're taking care of. So in this episode, our roadmap will be as followed. We're going to talk about the broad treatment goals and how we assess where patients are in terms of their disease. We'll revisit functional classes, talk about a few risk calculators, and then we'll conclude this episode with introducing the various treatment classes. But stay tuned. We'll have another episode delving into that a little bit more, but at least want to set the framework for future episodes. As you already heard from today, Tom and Rupali are joining us both. So great to see you both again and looking forward to this episode with all four of us.
Yeah, we're so happy to be here in this new year and looking forward to digging into these guidelines a little bit more and understanding the nuances. Maybe not quite to the level that Dave understands, but getting to grasp better on these guidelines. Really excited to be here.
Yeah, I second that. I think as we get into the individual disease groups as well, I think we're really going to learn a lot through doing all of this. So with that, let's get to it. As usual, we're going to start off today's episode with a case. I think that really helps us build a framework around how we're going to think about our patient. So this patient that we're going to talk about today is a 37-year-old woman. She's referred to you in pulmonary clinic because she had a echocardiogram done by her primary care physician for nonspecific shortness of breath. It was abnormal. And in taking your history, she explains that she's not short of breath at rest. She doesn't have any chest pain, any pre-syncope palpitations, but she has noticed that her ankles feel a little bit more swollen. She's still able to do all her usual activities, but feels like she does them slower than she used to. She's not providing you any history that's suggestive of connective tissue diseases. She hasn't been prescribed. She has never used, rather, any prescribed or recreational illicit drugs. And she's got no family history of pulmonary hypertension. On your exam, you're doing a really thorough examination, and you notice that she's got some dilated capillaries and reddish lesions on her face, her lips, and her tongue. But you don't see anything that would suggest systemic sclerosis, things like mouth tightening, sclerodactyly, anything of that sort. These skin findings then prompt you to do some additional history taking, and you actually learn that she has suffered from nosebleeds for quite a long time. Common things being common, she thought it was due to the cold weather and things of that sort. So with that background, Dave, how can you walk us through what you're thinking about with this information?
Yeah, great. Thanks, Tom. Very interesting case, a classic that we'll see in pulmonary hypertension clinic. with a lot of our patients being evaluated for pulmonary hypertension, they come in with sort of non-specific dyspnea and an abnormal echocardiogram. And it's important to have your antenna up. The pulmonary care doctors did the right thing, getting an echo, as we talked about in the first episode, and referring based on results. But a 37-year-old woman really shouldn't have significant dyspnea on exertion. There obviously can be broad differential for that, but pulmonary hypertension should be up there so that we don't get that delay in diagnosis. The findings in the history and physical that really jump out to me is that she's young and otherwise healthy, as you said. She doesn't have any of the classic exposures that we might worry about for pulmonary hypertension. So she hasn't talked about use of methamphetamines in either prescription or recreational manner. Given her age and lack of other comorbidities, the chance that she has significant left heart disease or an underlying parenchymal lung disease that we don't know about is a little less likely. We obviously are going to check for all those things. She had an echocardiogram, so we have some good sense that her left heart is likely normal. And there's nothing else particularly that I'm seeing for other groups. She hasn't talked about a history of blood clots. We would obviously check for that, but group 4 disease, or she doesn't have classic findings of sarcoidosis or things where we're thinking about group 5. So I'm thinking that this woman is probably getting that group 1, idiopathic, familial, or associated with other conditions. And that's going to be our main operating differential as we're going forward for her. The one thing on physical that you did point out is that maybe we see telangiectasias. And so this really is raising suspicion for group 1. And the two big categories of group 1 that this would raise for us is one, as you mentioned, systemic sclerosis. So even though she doesn't have other classic findings, we'd still have this in the back of our head. And we'd certainly send some antibody profile to make sure that this wasn't some early manifestations of that. But the other one that we can see for this is HHT, hereditary hemorrhagic telangiectasia. She's had epistaxis in the past, and so this is a possibility. And HHT can cause pulmonary hypertension in a few different ways. I'm sure we'll dive into that, but these are probably my main operating differentials for etiology for this patient at this time.
Yeah, that was awesome. Thanks, Dave. I like how you really took the time to build a differential from the key history and exam findings. Just a really good reminder of how important it is for us to focus on the bedside exam and that it still matters in addition to all the other objective data that we tend to get. So her exercise limitations were an interesting point that you brought up, Tom, and also helped us frame this patient by one of the things that we we're going to discuss today, the WHO functional classes, which really range from class 1, no symptoms during ordinary activity, class 2, symptoms with some ordinary activity, class 3, symptoms during less than ordinary activity in class 4, which is more symptoms even at rest. Since she's comfortable at rest, then she sometimes notices she needs to slow down when she moves around. This is more in the WHO functional class 2 group. So important to think about her history in terms of that. And then you did mention some of the objective data. And as a quick reminder, and to harken back to episode 1, I would be curious to know some other objective data that you may have, including her biomarkers, NT-proBNP level. If she had PFTs prior, I would be interested to know all the parameters, including the DLCO. And then you mentioned that her PCP referred her for an abnormal echo. And a quick reminder for all our learners, as we discussed in episode 1, that the highest yield finding on the echo was really the tricuspid regurgent jet velocity with a value greater than 2.8 meters per second, suggesting pulmonary hypertension. Other important findings that we should be keeping our antennas up for on an echo are RV enlargement, a reduced tricuspid annular planar systolic excursion or TAPSE, septal flattening, and even pericardial effusions. And this is just beyond the estimated PASP, which we often see patients referred for based on their echo. Dave, you have something to add?
Yeah, I just wanted to emphasize the point you made about the WHO functional class. This is a super important metric for us. And so we'll talk about the risk scores a little bit more. But sometimes it can be tough to say what's ordinary activity, what's less than ordinary activity. And so certainly some guide points for people. Class 3, if you can't do your normal chores around the house or your normal shopping without shortness of breath, then you're definitely in that class 3. Class 4 is pretty easy because you're at rest. For class 2 with less than ordinary activity versus 1, I often just ask people if they're walking at their own pace or they're walking with, say, a partner or a family member who's a similar age and healthy function status. Are they able to do that? Are they able to keep up? And if they are, they might be class 1, where it's really just with exercise that they're getting some major exercise that they're having more limitation. But if they're not able to do their own pace or keep up with someone who they think should be pretty much physiologically similar to them, then definitely in that class 2 group that we referenced already. But this is all great information. And Tom, I was hoping you could walk us through some additional diagnostics that she might have had.
Yeah, absolutely. So when she came in to see you in clinic, her vital signs were with a blood pressure of 125/80. Her heart rate was 90, which is a little on the higher side. She had an echocardiogram that her primary care doctor appropriately referred her for, which showed a dilated right ventricle with a basal diameter of 4.5 centimeters. Her TAPSE was 1.4. There was septal flattening noted on the parasternal short axis view. She had a fairly normal appearing left ventricle and left atrium. The LA wasn't dilated. There wasn't a lot of LV hypertrophy. And the tricuspid regurgitant jet velocity was 3.1 meters per second. She also came with some labs that included a pro-BNP of 900, normal kidney function, and you obtained some additional testing with pulmonary function testing. The spirometry was normal, so no obstruction or suggestion of ventilatory defects. Her DLCO was 65% of the predicted. She got a 6-minute walk test done, which was 300 meters. And then you rounded it out with some of those serologies that Dave was alluding to earlier, including a negative workup for HIV, connective tissue diseases, parenchymal diseases, and then you also had access to genetic testing. So she had a negative test for BMPR2, and she had a VQ scan that evaluated for CTEPH and was very low probability.
Thanks so much, Tom. That was a lot of great information that you just provided. And I think very reasonable to say that this patient has an intermediate to high pretest probability of pulmonary hypertension with a strong suspicion for group 1 disease, as Verf pointed out earlier. And I think, some great kind of positive things and some negative things in here too. Rupali, thank you for reminding us from episode 1 about the TR jet velocity. And that should be something that we're looking at in the echo as well. I think at this point, all 4 of us are probably thinking the gold standard and what we need to diagnose pulmonary hypertension is going to be a right heart cath. We're all thinking that's it. And if you're thinking that and you're listening today and you're like, where's the right heart cath data? You're exactly on target. And that's the next step that this patient needs. And ideally at a dedicated pulmonary hypertension center. And why does that matter? Just because these centers have the experience to get the hemodynamics, they can classify disease accurately and start the right therapies early, which is exactly what the guidelines emphasize and will ultimately translate into better outcomes for our patients.
Yeah, you're right on target, Monty. We're all thinking about the right heart cath. I hear some of our pulmonary hypertension faculty in the back of my head. It's a suggestion of pulmonary hypertension until we have the right heart cath. So this woman gets sent for a right heart catheterization, and you find a right atrial pressure of 5, a mean pulmonary artery pressure of 37 with a wedge of 9. The PVR is 7, the cardiac output is 4, and the SVO2 is 65%. Rupali, with all this information, do you think you could give us a summary of the case?
Yeah, thank you, Tom. This is a great time to pause and summarize. We have a lot of information, objective data, as well as data from the patient herself. And just looking at your right heart cath numbers, also thinking about all of our pulmonary hypertension attendings, right? Their first question would be, what do you make of that right heart cath? So can you tell us what you're going to do with that? So a mean PA pressure, 37, greater than our cutoff 20, right? So that's pulmonary hypertension there we've diagnosed. We look at our wedge pressure. We said, okay, like Dave had suggested and the echo suggested, and the patient had told us there doesn't seem to be a good element of group 2 disease or left heart disease. And that's confirmed based on that wedge pressure. And then you gave us a really nice high PVR of 7 Woods units, which is helping us lean again towards that first category. So if we pause and we take that information and we try and incorporate that with everything that we've heard, I would say that we have a relatively healthy young woman in her 30s who's presenting with progressive shortness of breath and was found to have, based on our right heart cath, isolated precapillary pulmonary hypertension with functional class 2 symptoms, as we discussed, no alarm symptoms that we're hearing on exam or concern for overt right heart failure, and non-severe hemodynamics based on this right heart cath. Given our history, physical exam, and objective data overall, I would say, as we suspected, I continue to be suspicious for a case of group 1 pulmonary hypertension from HHT-associated PAH. Dave, how else would you think about this case?
Yeah, awesome. So this is spot on, and we're in a good place to think about next steps for this patient. So one thing is I want to take from the right heart cath before we move on is that it is looking more like group 1 PAH, as you alluded to, or so you said. Just for some background, HHT can cause pulmonary hypertension in a couple different ways. Sort of the most common way is that you have AVMs either in the lungs or in the liver, and this is leading to actually a high output state. And so that it just has increased flow through the pulmonary vasculature that's raising the pulmonary pressures. It can often mimic sort of a group 2 type picture. But we don't see that here. Her cardiac output is 4 liters per minute. It's not excessively high. Her wedge is 9. And so we're not seeing this real increased dumping of flow into the left side. And you can see RVs that look really dilated and not happy just from that high flow state. We see that in liver disease. We can see that in HHT. And a patient like this would also have a CTA, and we would say that there's not some massive 4 centimeter AVM within the lungs where it's an isolated one lesion that we have to go after. In 1 to 2% of patients with HHT, you can actually get pure group 1 disease. It's often linked to this ALK1 mutation that they can have as well. And this just looks like true PAH, and the mechanism is just vascular remodeling that's associated with their underlying HHT. So that's really what we're thinking about for this patient. Several other important things that we want to think about with the information we have. So the severity of symptoms, as we already said, based on functional class. We already talked about how we can assess that. And she definitely has symptoms, but she's in that sort of early group 2 phase. And so we're hoping that she's in a lower or intermediate risk category. We do, even with these numbers and with that group 2, want to think about how acutely we have to act. So one thing we think about, even outside of risk scores, is just how concerned are we about the patient in front of us and these hemodynamics. And so, for example, you mentioned no alarm symptoms. Now, most of the risk calculators don't include this little one-liner, but if this patient told me that when she walks upstairs, she syncopizes, right? And that would be very concerning to me. And I'd be very worried about what's happening to her right heart under exercise conditions, given this is a resting cath. And so that might prompt me to say a patient like this actually has to come inpatient for further evaluation. Additionally, we know that the numbers, the severity on the right heart cath is not just linked to PVR or mean pulmonary artery pressure. It's a holistic view. Her cardiac output was 4. If we assume she's like a 70 kilogram average height woman of 5'2" or things like that, her cardiac index would be around 2.5 on the upper limit of normal to lower limit of upper limit abnormal, lower limit of normal. And so that's a little bit reassuring to us that she's not in overt RV failure. Whereas if her cardiac output was 3 and her cardiac index was 1.8, I might be a lot more worried about this patient and want to do things a little quicker. But we don't have those. So right now we have a patient who definitely has pulmonary hypertension. We have a presumed mechanism, and we're going to treat this as group 1 PAH. She's had a very thorough workup. And so our next step is thinking about treatment. And to determine treatment, we have to look at her risk stratification. And so this is how the Pulmonary Hypertension Guidelines recommend we do this. This is how pulmonary hypertension providers say we do this. And so we have to take all the info we have and put it into a risk stratifier to decide what's the best pathway forward for her.
Awesome. Thanks so much for going through all of that. Yeah, I totally agree. And there's a lot of different ways to risk stratify. And we'll talk about a couple of them today. And all of this is going to be in the guidelines for you to look at in more detail. But one point that the 4 of us wanted to make sure that we share today is that the 2022 ESC ERS Guidelines recommend that at diagnosis, I think it's important to, we're just diagnosing this patient with a new diagnosis of pulmonary hypertension. It's different at diagnosis versus when you're following up the patient longitudinally, when they're going back to see FERF in clinic, and he needs to make adjustments. But for patients with PAH at diagnosis, the guidelines currently say that they're stratified by a 3 strata model for risk of death at 1 year. So patients are either going to be low risk, so that's less than 5%, intermediate risk, 5 to 20%, or what we'll consider high risk, which is going to be greater than 20%. And again, why are we doing this? To really understand and be able to talk with our patients about the risk of death at 1 year and how we can potentially help modify that. And I like to think of the ESC ERS risk calculator bringing together 10 key variables. And I think an easy way for me to separate them in my mind is, again, in medicine, looking at things in 2 buckets. 1, what is the patient telling us? And 2, what are the data showing? So you'll be asked about things like signs of right heart failure, whether symptoms are progressing, functional class, and syncope definitely is its own separate category, as Ferf just alluded to, how important that is. But that's also going to be alongside objective measures such as biomarkers, hemodynamics, the 6-minute walk test, echo findings, cardiac MRI in certain cases, as well as cardiopulmonary exercise testing. And I just said 10 variables, that's a lot. You may not have them all at the beginning. We certainly don't have all of the information in the patient we're discussing right now. But even if data aren't available yet, which is very common in real life, you can still calculate a meaningful risk score as long as there are 3 variables are entered. And again, this is for the ESC ERS risk calculator. I do want to bring up another calculator at this point too, and we can probably talk about this a little bit further on, and Tom will probably give us some numbers. But another commonly used tool is Reveal 2.0, which really builds on the ESC ERS framework. So it takes those same core clinical and diagnostic variables and layers in some additional contexts with variables including demographics. It's going to include renal function now, blood pressure, and then we'll actually ask about PFT, specifically DLCO, to move us really beyond a single snapshot and toward a more longitudinal picture of risk. So when thinking about both of these calculators, another way I like to separate them in my mind is I like to think of ESC, ERS to quickly frame risk when data are still coming together. And sometimes I turn to Reveal 2.0 when I'm refining prognosis over time or guiding escalation and follow-up. Tom, I'm sure that you are busy inserting these numbers into the calculator right now, but what else can you share with us about this patient?
Yeah, thanks for walking through that, Christina. These risk calculators are really important, as Dave alluded to, for how we manage our patients. And fortunately, they're actually really easy to find. If you simply Google pulmonary hypertension risk stratification or something to that effect, you'll be directed to good websites where you can calculate these. So based on the data that we have, the ESC ERS calculator places our patient with an intermediate risk score of 1.6, and Reveal 2 puts her at an intermediate risk score with a score of 8.
Wow. Thanks, Tom. This is another good place just to pause for a learning point for all of us. Christina mentioned that risk stratification is so important, especially at diagnosis when patients are coming in unsure of their diagnosis and unsure of what that may mean. So based on her symptoms, as you described, our patient sounds like she had what she described as milder disease with functional class 2 symptoms. But then when you really enter her data into these risk calculators and you think about it, this is a young, healthy 37-year-old woman with what you described as an intermediate. And as Christina told us, that correlates to a 5 to 20% risk of mortality in the next year, which is definitely extremely meaningful. Dave, I know we're going to go through the nuances of all the different classes of PH therapies and the individual disease groups in the upcoming episodes, but per your expertise, just curious, what are some of the things at this point, having all this information, having done the risk stratification, that you're thinking about when you're trying to decide when and what therapies to start a patient like this on?
Yeah, absolutely. That's our next step, is what is the best treatment for this patient? I just want to comment a little bit on the 2 risk calculators. This is a great example of the fact that there are many risk calculators out there. We'll talk in follow-up. There's also Compara. There's a French non-invasive. Most of them use some key factors that are always in there. WHO functional class, 6-minute walk distance, NT-proBNP. They don't all have the same other factors. So ESC ERS takes a much more in-depth look at CPET. It's a great guideline for you as a provider to say, hey, what are we looking for on CPET? So for example, on CPET, they care about the peak VO2 and then the VE VCO2 slope. These are the main things that we care about when we're getting a CPET for these patients. They also incorporate hemodynamics a bit more from the right heart cath. In the Reveal 2.0, all you get from the right heart cath is ways to get lower points. You don't actually get higher points. So if your PVR is less than 5 or your RA pressure, if your PVR is less than 5, you remove a point. If your RA pressure is higher than 20, you get a point, but it doesn't look at everything else. Additionally, the Reveal 2.0 doesn't look at everything on echo. All it says is if you have a pericardial effusion or not. And pericardial effusion is a big risk factor for us. So we would definitely layer that in. But interestingly, even though they take these different factors in, and I encourage you to look at both these scores, we'll post links and pictures of the different scores. If you run patients through, you almost always get the same category because they're taking in some core incorporating factors and they're very holistic. And so it's not ever just one piece of data. It's always looking at a few pieces of data and things that you should always think about: 6-minute walk, functional status, and NT-proBNP. These ones are key for all of the risk calculators. So we know this patient now is in this intermediate risk. We talked already about whether or not she's concerning that we have to bring her to the hospital. And I don't think she is, right? I think that she is a standard patient that we could treat in the outpatient. But we want to talk to this patient about what we're trying to do with treatment. We want these patients to feel better, live longer, stay out of the hospital, and ultimately maybe modify their underlying disease process so that they get out of this window of having PAH. Now, that comes in with some of the new drugs, but remodeling of the RV and then maybe even the pulmonary vasculature is our ultimate goal to prolong their life and decrease their morbidity or mortality. I always tell patients with this, like a patient like this, if you Google pulmonary hypertension, it's going to be really scary. And it is, if you're a young woman who's 37 years old, before this visit, your risk of mortality in 1 year was presumably 0% or very low, 0.001%. Now you're telling me it's a 5 to 20%, maybe 1 in 20 to 1 in 5 people are going to be dead in a year from this. And so I always tell them, this is to help us guide. We are going to get you off of that curve. That is our goal with treatment. And an important thing for us to know as providers is there's very good data that time from diagnosis to getting to low risk is hugely impactful on the patient's morbidity and mortality. So that is our goal. As we say, right now you're in this intermediate risk. We are going to get you on meds. We're going to talk about the side effects of those meds, but our goal is to both make you feel better, but get you in this low risk. So that risk of morbidity and mortality is going to go down significantly. I also always explain to them that we are going to be reassessing this very frequently. So after a patient like this, I'm going to see at least every 3 months, maybe even more frequent than that, until we're in that low risk category, right? Because I want to be constantly reassessing, seeing how we're doing, seeing how they're tolerating the meds, and adjusting to get to low risk as quickly as possible. When they do come back for that reassessment, because we're going to talk about treatment at the end of this and a little bit separately, but a patient like this in the intermediate risk is almost certainly going to be on a combination therapy. It's going to be oral therapy. We're going to try to see how they get on it quickly and see how she's tolerating. And when she comes back, we're going to reassess her functional class and her risk status. And we're going to use different risk calculators to do this. So there are a couple different ones that do this. There's the Compara 2.0, which is a 4 risk strata calculator. There's Reveal Light 2. There's the French non-invasive criteria. All of these have pretty good data behind them. The ERS Guidelines recommend using the Compara 2.0. And this is incorporating functional class, NT-proBNP, and 6-minute walk. And then it's going to put us in low risk, low intermediate, high intermediate, and high risk. I personally use the Reveal 2, which includes some additional variables. That's systolic blood pressure, heart rate. And these are like pretty binary. Like your systolic blood pressure is greater than 110 or less than 110. Your heart rate is greater than 96 or less than 96. Incorporates GFR as well. And I just want to see that we're making progress. So patients tolerating well, even if the cath numbers look better or the echo looks a little better, if we haven't gotten down to that low risk, it's time for me to escalate that therapy a little bit more. So I want to see that we're embarking on this goal to get that. I'll emphasize to that patients that we're going to get the pH under control, that after we do, they're going to have a normal life, normal functionality. And our whole goal is that their mortality risk is going to go way, way down from where we started. And then I want them to call me all the time and never feel like there's any issue they can't raise, because I can always get them back in earlier. And we have lots of therapies we can escalate to if we're not meeting that goal. The last things I'll say is when we're diving into treatment like this for a young woman, very important to talk about conception for 2 different reasons. Multiple of our medications are teratogenic. And so some of them we're on REMS, which is this monitoring system where we have to get monthly pregnancy tests and people sign a contract that they're going to use 2 forms of contraception. A lot of them have actually come off REMS, and we'll talk about that more in the treatment, but we still know they have that teratogenicity. So we want to counsel on that. But 2, pregnancy and pulmonary hypertension don't mix well. When you're pregnant, you have high circulating volume. Those pressures that were already high in the lungs start to increase dramatically. Patients can do very poorly, endangers the life of the mother and the fetus. And so we want to counsel at this stage that conceiving now would not be a good idea. If we achieve low risk, then we can talk about how we can get someone successfully through a pregnancy. So those are 2 things that we just definitely that's one thing we definitely want to talk about. And then this is a very overwhelming diagnosis. So just cancer or new diagnosis of an organ failure, like renal failure, like people need support, and there's plenty of support out there. And so we want to make sure that they're plugged in with patient support groups, with the PAH groups, anything that they can get. And there's a lot of resources that they can have to discuss this diagnosis and learn more about it.
Awesome. Thanks, Dave. I think one of the most important things you said there, in addition to all that, it was all fantastic, but one of the most important things was how life-altering these diagnoses can be and how we need to take into account risk stratification, know what the cath is, but we also need to attend to the patient's psychosocial needs and make sure that we're providing good humanistic care, because the patients come to us scared and they need guidance and help, and if you type into Google, anyone's going to get scared. So we have a huge role in how we help these patients beyond just the medications we can provide. We've alluded to this, and this is an episode in and of its own, but in the time that we have left, I want to make sure that we jump into some of the different types of medication classes that we can use to treat our patients, particularly those with pulmonary arterial hypertension, PAH. In our coming episodes, we're going to talk more about these, what patients should be getting these therapies. Should a certain patient be getting them at all? That's an important thing to think about. The first class of drugs that we're going to talk about are those that act on nitric oxide signaling. So these are the phosphodiesterase 5 inhibitors. These are sildenafil and tadalafil, probably two of the most well-known drugs within the armamentarium of pulmonary hypertension drugs. These prevent the breakdown of cyclic GMP. This is the second messenger in nitric oxide signaling, throwing all the way back to cell biology. These drugs find themselves in pretty much all PAH regimens, but they can be used off-label as well, or in the setting of clinical trials for other pulmonary hypertension groups. Another drug that acts through the nitric oxide pathway is riociguat. This is an oral medication. This directly stimulates guanylyl cyclase to then produce cyclic GMP. It's a little different because it's able to stimulate the production of cyclic GMP regardless of the presence of nitric oxide. It's also important, these drugs should not be used together. You can cause pretty significant side effects and hemodynamic consequences if you use tadalafil with riociguat, so it's a one or the other choice. And I'm going to throw it over to Rupali to talk about our next class of medications.
Thanks, Tom. Yeah, this is great. I remember first as a pulmonary fellow trying to learn about all these classes of medications, and I'm really getting confused, but I love that we're breaking it down by where they act, how they act, and grouping them. The next class of drugs I'm going to talk about are the endothelin receptor antagonists, commonly referred to colloquially as ERAs. These drugs act on endothelin A and B receptors, and specifically the B receptors are particularly highly expressed in pulmonary vasculature. The classic drugs are the TAN drugs that we think of. And the classic one is bosentan, although in practice, it's not used as commonly these days as much due to many side effects and drug interactions present with the drug. The other more commonly used choices include ambrisentan and macitentan. It's important to note, as Dave mentioned, that all these drugs are teratogenic. So we'll dive into that in further episodes as well. The next class of drugs I want to mention are the prostacyclin agonist. These are potent vasodilators that have some anti-proliferative properties as well. The prototypical drug is epoprostenol, but given its short half-life and challenges with administration, it's not used as much. Much more commonly these days, what we're seeing being used is treprostinil, which can be given in many different formulations, IV, sub-Q, oral, and even in newer inhaled formulations. We may all know the brand name Tyvaso. Selexipag is also another distinct prostacyclin analog available in oral form and can also be used in some situations. Monty, can you tell us, these are some of the drugs that are mentioned in the ESC ERS Guidelines from 2022, but could you maybe tell us about some other drugs that are newer?
Sure. Thanks, Rupali. And I know that you and Tom are going to come up with a great infographic for us to try to remember the different classes of medications and how they work. But yeah, so you're exactly correct. When the guidelines came out in 2022, the newest, trendiest kid on the block, sotatercept, had not been approved yet. So this is, I think we all know this now. I'm interested to see how often FERF's able to prescribe this. But for those of you, just a quick thing on sotatercept. It's the newest pH medication. It's an active ligand trap that works along the TGF-beta signaling pathway, targeting those pro-proliferative signals that really drive disease. I think there's probably lots of different exciting things for this medication, but I think, at least from my perspective, what I've heard and all the trending news, it really has the potential to be really truly disease modifying rather than simply additive to the existing therapies. Before I send it back to you and have you comment on sotatercept, I do just want to add a quick antidote for understanding these medications, but where are we potentially as trainees probably should not be the ones prescribing or re-prescribing these medications. I remember as a clinical fellow, it was a Sunday, I got a call from the ED about a patient who followed in our pulmonary hypertension center here, was out of medications. They were trying to send her home. So they asked if I could just refill her medication. And I was trying to be helpful. And I said, sure, I can. I quickly learned Monday morning that I could not, and probably not something that I should do for all of the reasons that you talked about, understanding the teratogenicity, being in REMS program, etc. So just wanted to call that out. If you get a weekend call to refill someone's pH therapies as a trainee, probably should not do that and call an adult. But I'm going to send that back to you. Anything else you want to add from that comment or anything else you want to add on sotatercept being the newest kid on the block?
Yeah. When your heart was in the right place, you're doing the right thing. But, there should always be a pH provider available. I think one thing, when you become a pH provider, you are signing up to be available for your patients in some capacity for these types of emergencies, because a lot of these medications are very high risk and really need some expert management. Sotatercept is a game changer in our paradigm. It is being used a lot. It is very easy to get, actually, Christina. It's not tough, even though it's a new drug, because the data is so convincing. And the FDA has approved it very broadly for anybody who's on therapy and still with group 2, group 3 disease. And so it's not a difficult drug to get. We will focus in this series on the guidelines, which came out before sotatercept. And I will say that we will comment on sotatercept throughout the series and when or how it may be used. But the field is still learning about this. And so it is definitely very clear that if you have group 1 disease and you're on max medical therapy and you haven't achieved goals, we're adding sotatercept. That is like the slam dunk. And ongoing trials in different risk stratifications have all shown the same thing, that it's extremely effective. Where it comes in earlier in the regimen, how early you start it in a patient is still a little bit of a question. And so we'll comment on that kind of throughout the series. The disease modifying thing is the major impact of this. It also is quite a good pulmonary vasodilator. People feel better on it. It improves everything else. And I'll say some of our other drugs, all our other drugs are mostly pulmonary vasodilators. There probably is some remodeling that happens. Like, we've all had a couple patients who've been on prostacyclins for a long time, and then their physiology shifts and they just don't seem to have the same pulmonary arterial hypertension that they had before. But mostly those old drugs are pulmonary vasodilators to get someone to a good steady point so that their RV never has negative impacts. Sotatercept, it's seeming, is acting based on this mechanism that was discovered from people who have the BMPR2 mutation, the most common hereditary form of PH, who acts on a pathway that was investigated through those patients. Looks like it not only is giving you pulmonary vasodilator effect, but it's actually acting on those pathophysiologic remodeling of the vessels. And while there's no data on this yet of whether or not you could use it and then come off of it, the idea is that hopefully it is changing the way that they will progress over time. It's also home injected sub-Q every 3 weeks, much more convenient than our treprostinil or epoprostenol, which are often continuous infusions for someone who has severe disease. And so a big impact on this. Outside of sotatercept, I just want to make a comment now that we have a vocabulary for these drugs of what we do with our risk stratification. And there are some nuances in here and there's some style preferences, but there are some things that are very clear. So let's start with the most clear one. One is if you have a high-risk patient at initial diagnosis, your go-to should really be prostaglandin therapy. This is V or sub-Q right up front. It will change based on who the provider is in the center, whether or not you're doing that outpatient or inpatient, whether you're doing that with a SWAN or without. Like, for example, we often do that inpatient. We often do that with a SWAN, but some people do things differently. But really, a high-risk patient has that greater than 20% one-year mortality. You have to get those numbers down quickly. You have to reverse the risk status. So you really should be leaning on our most tried and true therapies, epoprostenol, treprostinil, IV or sub-Q. For patients who really can't do IV or sub-Q for some reason, You could think about triple oral therapy up front. Sometimes we'll even bring someone in, get them an IV, just fix the numbers, and then transition them to a triple oral regimen if for some reason they really can't do home sub-Q or IV. But even with the addition of sotatercept, which will be started in those patients almost invariably now, high risk, really think prostaglandins and in a parenteral fashion until you get that risk improved. For that intermediate risk patients, again, there's a little bit of style. There's definitely a lot of questions about sotatercept, but we know at least upfront combination oral therapy is going to be needed in these patients. There might be that high intermediate risk where you're thinking about parenteral. There might be that patient who you just feel like you want to get the control faster, and so you're going to go to the highest, most aggressive treatment regimen. But at least upfront oral therapy combination, that is at least 2 drugs, and that'll be a PDE5 and an ERA. And then depending on the patient, some people go straight to triple therapy up front. And there's been some trials on this. We'll talk about the trials in our ongoing treatment episodes. And we're going to break those treatment episodes down by etiology, like if you're group 1 PAH versus group 2 versus group 3. And so we'll talk about those nuances. But definitely be thinking 2 to 3 drugs for that intermediate risk. And in that low risk patient, this is where at least 1 oral drug, but really a lot of us still use a combination of 2 oral drugs, an ERA and a PDE5. It depends on how low risk is and what their underlying etiology is. So if they have scleroderma, we know this progresses. We're probably going to be pretty aggressive about getting them on a regimen that they can tolerate. But that low risk category, we have some time, definitely outpatient, definitely we can layer things on and monitor side effects quickly, but we have some good information that those 2 pathways work well together. And we're probably not adding oral or inhaled prostaglandin analog or selexipag or anything like that for if they're staying in that low risk, because we've already achieved it, but we do want to still monitor them pretty closely. And so that's how we put our risk stratification into practice. And yeah, you can ask me specifics about when to start sotatercept. Big question. Patients ask all the time, and the field is still evolving to figure out what the right answer is.
Awesome. Thanks so much for some short-term recall. Before we end our case for today, for this specific patient who is intermediate risk based on the guidelines and the risk stratifiers that we used, I'm hearing that you would start at least oral medication, at least 2 therapies, but would you do 2 or 3 in this patient?
I'd probably start 2. I'd probably start tadalafil and ambrisentan. This is based on the Ambition trial that we'll talk about going forward. There's a whole pathway in the Ambition to get to full dose of both of those and how to monitor. You can even go quickly. There is a drug out there with macitentan that's a combo 1 pill. And so if pill burden is a huge deal for this patient, I might go with that one. But classically, definitely a PD5 and an ERA, probably tadalafil and ambrisentan based on the data. Maybe one of the other ERAs for convenience. And then I would reassess. I could definitely get to goal and then see her in 3 months, redo one, probably my Compara 2.0, and she's down to low risk and even really low risk based on how many points she gets. I might be happy there. If she has not achieved low risk and she's still in the intermediate risk, time to add, probably I would do selexipag or another cyclin.
Awesome. Thanks so much for so much to still talk about. And I know that we can talk about this for much more than we've talked about it today, and we will, but we'll be coming back with another episode. It's been a fantastic discussion so far, and I think a natural place for us to take a pause for today. As we've talked about in our upcoming episodes, we'll dive a little bit deeper into the different WHO groups of pulmonary hypertension, walk through more treatment options available for each, so make sure that you stay tuned for those episodes. Thanks for all of y'all's help today and for coming on.
Yeah, thanks, Tom and Rupali. Appreciate it. Thank you all for listening. This episode was written and edited by Tom and Rupali, and Christina and I layered in a few minor points. And then it was produced by myself and Christina Montemayor. Music is original music by Eric Rogers. And we'll see you next time.
Thanks, everyone.
Thank you.